All right, good afternoon, everyone. On behalf of the Center for Primary Care at Harvard Medical School, I'd like to welcome you all to our webinar today. My name is Megan Lenneman, and I'm the program manager for the center's education team, and I'm here with my colleague, Erin Farron, to help facilitate. Today's session is part of our Scaling Community Outreach and Primary Care Education series, and we're so glad you can all join us. Here at the Center for Primary Care, we are committed to uncovering, promoting, and fighting for the best and most efficient ways to deliver high-quality primary care around the world. As part of our mission, we aim to connect our community to information and resources to empower them to join us in this work. And we're excited to take these efforts online with our S.C.O.P.E webinar series. Today's talk features Dr. Nathaniel Van Kirk, who will discuss reducing stigma for providers with mental health diagnoses. Dr. Van Kirk is a licensed clinical psychologist specializing in the conceptualization and treatment of severe anxiety disorders, obsessive compulsive disorders, and trauma PTSD. Currently, Dr. Van Kirk serves as the director of inpatient group therapy for McLean Hospital and Harvard Medical School, and the coordinator of clinical assessment at McLean Hospital's OCD Institute. He received his doctoral degree in clinical psychology from Virginia Tech, and his clinical research specialty focuses on the role of motivation across treatment and the impact of trauma, comorbid PTSD on treatment outcomes in OCD. Additionally, he is involved in regional and national efforts to reduce the stigma surrounding mental health, including participating in the Deconstructing Stigma campaign, focusing on the importance of bridging the gap between therapists, researchers, and those with mental health challenges. So we're so thrilled to welcome him today. A few housekeeping items. There will be a Q&A session at the end, but I encourage you all to please submit your questions throughout the presentation by clicking on the Q&A icon at the bottom of your screen and typing in your questions. You may also use the chat feature. We will do our best to answer each submitted question, and we hope that you do submit those throughout his talk. I'd now like to turn this over to Dr. Van Kirk.
Thank you very much, Megan, and thank you to you and Erin for inviting me to join today. It's great to see we have a number of people in attendance. And so today, what I'm hoping to talk about a little bit is the impact of mental health stigma, specifically as it relates to the medical field and the mental health field, but also how it relates to us as providers and some of the unique challenges that it presents. So my hope is that I'll probably do about 30 minutes of just going over kind of some of the basics of stigma, how it plays out, the different types of stigma, some of the things that we can do to challenge it. But I also wanted to leave about 30 minutes at the end just for Q&A to have a discussion for those that are here and kind of talk about some of the areas that are most interesting to you, but also some of the questions that you have. So in order to go ahead and get started, I'll share my screen here. And so as we talk about this idea of reducing stigma for providers with mental health diagnoses, I really wanted to just start out by kind of setting the stage a little bit and talking about some of the statistics around mental health that many of us may already know or come across, but I think it's important to reiterate whenever we get a chance. And so really to start, I want to answer a little bit about the question of who struggles with mental health challenges. Unfortunately, the concept of mental health still is a little bit in the background. It's gotten much, much better over the last decade. However, openly talking about mental health still carries a lot of stigma and a lot of challenges with it, especially even within the medical field itself. And so when we really think about who struggles with mental health, it isn't always necessarily talked about as something that is kind of universal versus something that a few people might experience. But when we look at the data, and this varies year by year, but some of the most recent data is showing that 1 in 5 American adults will experience mental illness within a given year. So this is a 1-year prevalence rate. Additionally, we know that about 355 million people are affected by depression, making it one of the most common disorders in the world. And that psychiatric disorders are one of the leading causes of disability in the US. And many of this data is replicated across the world as well. However, if we zoom out a little bit, I actually wanted to talk a little bit about the lifetime prevalence and kind of think about mental health challenges across the lifespan. What we do know, there was a wonderful study by Kessler and colleagues in 2007 that really looked at some of the national kind of comorbidity sample and found that about 47.4% of individuals report a lifetime prevalence of mental health challenges, meaning at some point, and this was before the age of 75, 47.5% of individuals will report having a mental health diagnosis at some point during their life. A subsequent study also looked specifically just at adolescents and children, those up to age 18, finding that actually about 49.5% of children and adolescents reported having a mental health diagnosis at some point during that window. So if we really take these two together, mental health challenges are actually more of the norm. They're kind of a flip of a coin, if you will. And one of the interesting things is when looking at the statistics, the authors were able to kind of model the projected lifetime risk when you expand out past 75, finding that that increases the lifetime prevalence to about 55.3%. And I think this is really important to kind of share and discuss, because a lot of times when you're working with mental health or you're going through mental health challenges yourself, there is that notion that not everybody struggles with this, or I'm not supposed to be struggling with this. And the impact of stigma can be really powerful. However, we really know that 1 in 2 people will be affected by mental health challenges. In addition to that, if you think about those that are affected by mental health challenges due to having a significant other, a loved one, family member who struggles with mental health challenges, that almost everybody at some point in time will have an experience with mental health, that we can all kind of understand that challenge together. And so I think these are important ways to kind of set the stage. And while we may know these statistics, and even within the medical and mental health fields and behavioral health fields, we know all these statistics, we know that they're out there, but unfortunately, stigma still exists within these fields. And so I wanted to take a moment just to talk a little bit about kind of what stigma is, how we define it, some of the challenges that come from it, and what are the different forms that it may take. And so when we're talking about stigma, we're really talking about a set of negative and often unfair beliefs about a group. And what's important about mental health stigma is many times this unfair belief or this overgeneralization does tend to come from misinformation. And as I'm sure everyone that's here with us today can attest to, there is a lot of very, very terrible information around mental health all over the place. And that includes within the medical and mental health fields. Unfortunately, these negative sets of beliefs, they tend to take hold when there's a bunch of misinformation out there. There are also 3 main components of stigma that I think are important to highlight. The first is this set of beliefs or the stereotypes that come about a lot of times due to that misinformation. But from there, there's also this next phase, which is the emotional agreement with the stereotype beliefs. And I think it's important to differentiate these 2 aspects of stigma. Because while many people may find themselves or notice that they might have an implicit bias, or they may have a heuristic that they're using to categorize large pieces of information, like we do as humans, there's a difference between noticing it and challenging it and changing it, and then that next step, which is that emotional agreement. From there, you also have the behavioral consequences of that prejudice or the emotional agreement, which comes to the discrimination component of stigma. And so these 3 aspects span the kind of continuum of what we talk about as stigma from kind of the research and clinical framework. Now, there was recently in the Journal of Health and Social Behavior, some honestly unfortunate and somewhat scary statistics published, where they actually talked about the percentage of Americans that report feeling unwilling or may potentially feel unwilling to have an individual with mental illness interact with them in a variety of different domains. So for example, they found that about 38% of individuals weren't sure if they would be comfortable having an individual with mental health illness or mental illness moving next door to them. 56% reported that they don't necessarily want to spend an evening socializing with someone with mental illness. And then another piece that we're going to come back to and talk a little bit more about today is that 58% of individuals reported that they were unsure if they'd be willing to work closely with someone who has mental illness. However, if we really take these numbers into consideration and compare them to the prevalence rates of who's affected by mental illness, it really paints the picture that most of these individuals may actually be in contact. They may be spending evenings with individuals who have mental health challenges or mental health diagnoses. They definitely work with individuals who have had challenges and don't realize it. Because, and this is showing, to me, that shows the power of public stigma and of misinformation. Because if they really knew how prevalent mental health challenges were, they'd realize that they're doing all of these things already. And I think that education can be a really powerful way to combat mental health stigma, both in the community and within the medical and behavioral health fields. But this data also really kind of highlights one specific aspect of stigma, and that's the aspect of public stigma. And so when we talk about public stigma, we're talking about the beliefs that are held by the general public about a group and the reactions based on those beliefs. Now, these are actually probably the most common, if you will, kind of discussions that occur around stigma. And in a minute, we're going to talk about some of the other variations in how stigma may present. But I wanted to just kind of highlight that a number of recent studies actually show that around 75% of individuals with mental illness report that they've experienced some sort of stigma within their lifetime. That's a really high percentage. And so when I'm discussing this, and we can talk more about this in the Q&A, but one of the things outside of the clinical and research framework, in which my kind of clinical interest in stigma and the research interest that brought me here, another aspect of what brought me here today and why I focus on talking about the impact of mental health stigma is that in addition to being a clinical psychologist, I'm also an individual with lived experience. So when we look at those national comorbidity samples, they found, and that statistic that about almost 50% of adolescents and children report having an onset of a mental health diagnosis, I would fall into that category. So when I was an adolescent, I was diagnosed with obsessive compulsive disorder, and I'm happy to talk more about the experience if people have specific questions. But the point that I kind of wanted to make is that when I think about public stigma, I can also think back to one of the first times that I experienced public stigma within kind of the mental health field. And that was at some point as my symptoms progressed and treatment wasn't really going well, I got labeled as treatment refractory. And I remember this comment that was provided to my family that was, in all honesty, your son will be lucky to hold a job at Walmart. That's what you should be aiming for. And you should expect that you will have to care for him and make his decisions for the majority of his life. Needless to say, the therapist that said that was wrong. That was actually kind of one of the motivating factors for me to kind of switch my previous life plan, which as a 12-year-old, I'm not sure who makes a life plan to go get an MBA, but I did. That quickly went away and decided that I was going to become a psychologist, partially due to the reaction to the kind of that label and experiencing what that stigma was and wanting to do something to fight against it. Now, as I kind of go through the story, and we'll talk a little bit more about some of those experiences, but there was another element of public stigma that really actually came into play when I started to enter graduate school. And so when I was entering graduate school, I had an advisor that I was very thankful for that actually gave me some of the best advice I'd ever had. But it was also some of the hardest advice for me to hear, which was when applying to your doctoral program, I wouldn't recommend disclosing your history because a lot of times that will be considered a red flag, whether it should or whether it shouldn't. That's the reality. And today I want to talk a little bit about what the research, what clinical experience, and what kind of some of the discussions with colleagues have really pointed to is what is the reality and what are the things that we can do about it? Because I think it's important that we don't necessarily sugarcoat the fact that stigma exists, but really understand what are the unique challenges, especially for those of us as trainees and providers. There are some unique challenges that are important to be aware of so we can effectively deal with them and handle them. From that point, it did also give me the opportunity to think about and think very purposefully about how I wanted to use things like advocacy and self-disclosure, but also how did I want to frame some of the clinical and research work that I do on stigma to kind of make the maximal impact and change. Over the years, as I went through graduate school, I actually then started to become aware of another form of stigma that I think actually can be even more insidious when it comes to the impact that it might have on individuals' lives, especially providers. And that is the impact of self-stigma. So self-stigma is essentially the internalization of those public stigma beliefs, where an individual turns those beliefs against themselves due to their membership in a category. And when I think about us as providers, or for those of you that are trainees, I think this can play out in a variety of different ways when you're going through medical or behavioral health or mental health training. Because a lot of times what makes self-stigma so tricky is that you don't always notice that it's occurring. A lot of times these messages about mental health may be presented in normal day-to-day kind of conversation. So they might be kind of interpreted almost as societal facts versus opinions. Or there may be certain messages that come across in the trainings that you receive about how people think or talk about mental illness. And when you as an individual or as a provider are struggling with mental health challenges or considering the idea of seeking support, because let's be honest, 2020 has been a very difficult year, especially for providers. And there's no time that I can think of that more so than now that we need that support. It's important to reach out for that support. Unfortunately, some of these messages, especially if they may become unintentionally from people that you admire or those that are seen as supervisors or superiors in the field, can be even more powerful. And you may not even always know that they're occurring. For some of the ones that I hear a lot is this idea of, well, now that I have a mental health diagnosis, or because I had one in the past, I'll never be able to be successful. Or I'll never be normal is a common one that I hear from many clients. But when we think about, when I talk with providers, some of the ones that come up the most are these ideas that I shouldn't need help. I'm a provider. I'm a clinician. I'm a doctor. I'm a nurse. I'm a social worker. I'm a therapist. I shouldn't need help. I'm supposed to know these strategies, know these skills. I've been trained in this. I'm supposed to help others. I can't let anyone know that I'm struggling to use these skills or let anyone know that I'm struggling. What if people find out? What will my colleagues think? Will they think that I'm not dependable? A lot of these thoughts are ones that may come to mind pretty much behind the scenes until someone's starting to look for help or think about seeking help. One example of this that I just want to share is actually once I'd finished graduate school and I've been working in the field, I learned a lot about psychopathology. I learned a lot about a lot of different topics, clinical interventions. I also learned a lot about myself. And while I'd been in recovery for a long time, I also was able to look back on my life and realize, all right, there are maybe some things that were missed. One of those things was that as I started working full time, I started to realize I actually have the attention span of a squirrel. And I'm probably more similar at times to Doug from the movie Up. And I realized that not only did I have anxiety, but I actually had pretty bad ADHD. And while knowing this, there were options available and I knew what they were. But this was one of the first times I came face to face with my own kind of self-stigma that I didn't even realize was there. Because when I thought about the idea of actually reaching out for help, to essentially doing the things that I would suggest to my clients, the things that I know are effective for ADHD, I found myself delaying and procrastinating taking that step and starting to worry, well, because I do advocacy, I'm already known as the therapist that has a history of OCD. If I add ADHD to that, what are people going to think? Will that be the straw that breaks the camel's back and that all of a sudden now I definitely am not seen as reliable? And so I did what I think many of us in the mental health and in the medical field are taught to do. When things get stressful and overwhelming, you put your head down and you work harder, you work longer. Now, I eventually was able to kind of combat that mental health stigma and that internalized stigma for myself and take that step. And I really wish I'd done it many years earlier. It made a lot more sense as to why I really liked caffeine. And I felt calm when I was drinking coffee or soda at 9 o'clock, 10 o'clock, or midnight while I was working on papers. And one of the things when I reflect back on this and I do the stigma work is realizing that sometimes the most challenging part of self-stigma is coming to terms with some of the things that you learn about yourself, but even the fact that that self-stigma is there. And I think an important message that I hope everyone can take from today's talk is that everyone can be susceptible to self-stigma. It doesn't matter what your role, what your profession is, but we are all susceptible to it. And so it's important to reflect and notice when that comes up. because it can also be a way to help grow and take those next steps to combat stigma, but also to seek the support that might be most beneficial, even when that's challenging. And we're going to talk a little bit more about some strategies that the research shows can be effective in combating that self-stigma. But more generally, just to give a little bit, kind of go back to this general overview, we do know that across the board, there are many subtle impacts of stigma. The first is that it unfortunately leads to feeling unmotivated. A lot of times, if you feel like I can't do this or others don't expect me to, or they believe I'm going to fail, it can be hard to get motivated to do some of those tasks. Additionally, it's related to increased feelings of shame and guilt, lowered self-esteem and self-efficacy. And one of the most common pieces is that it can slowly build and lead towards greater isolation, both from peers, colleagues, friends, and family members. And while these are the ones that we see in the community, we can also see how these subtle impacts actually play out in treatment-seeking behavior. In a study in '93, they actually looked at community samples of individuals who reported mental health diagnoses and challenges, and asked how many of them actually sought help, finding that less than 30% of individuals in the community actually reported seeking help for mental health challenges. To me, this really demonstrates the power of that stigma can play and the stigma can have on individuals and what they choose to do next. Now, we might be thinking that as providers, as professionals, as trainees, that it might be a little bit better in the medical and mental health and behavioral health fields. Unfortunately, while there isn't as much research out there as we'd like to see, the research that is there does paint a little bit of a different picture. And that includes that a study of medical residents found that only 13% reported seeking help, while 82% of medical residents reported moderate to severe stress. However, very few of them felt comfortable reaching out for help during those times of moderate to severe stress. When we break it down a little bit further and look within the mental health field and look for mental health providers, so social workers, therapists, psychologists, psychiatrists, nurse practitioners, mental health specialists, we actually found that 57% of mental health providers reported that they did not seek help when they knew it would be beneficial to do so. And so I think these really reinforce the fact that mental health stigma and barriers to accessing mental health within providers is a very real problem and something that requires kind of an active focus. The other thing that can be that's really concerning when we think about this is that when we look at a subset of stigma called help-seeking stigma, specifically within providers, they actually found that greater endorsement of stigma around seeking help as a provider was actually related to higher levels of burnout, specifically the depersonalization aspect of burnout, which refers to cynicism or detachment from personal or clinical interactions. And when we talk about the idea of burning the candle at both ends, I think this really kind of highlights that as the training to just work harder, work more, work longer comes into play, our risk of burnout increases. And so kind of reaching out proactively is actually a really important part to maintaining resilience as a provider as you go through your career. So let's talk a little bit about what gets in the way of seeking help. When looking at these studies that surveyed specifically providers and trainees, they found that there are a couple re-emerging themes of what got in the way of seeking help for mental health challenges. The first of which was actually the fear of the stigma associated with a mentally ill label. This is one that across studies continue to come up over and over and over again. The next was this fear of being seen as weak or being seen as unreliable or having your work second guessed. And this also was related to the idea of concern over colleagues finding out, what are my colleagues going to think if they find out that I am seeking mental health help? Will they treat it the same as if I was going to do my yearly physical or taking care of a medical challenge? Or will it be seen as something different, something indicative of weakness? And unfortunately, this gets back to, there have been four main types of mental health myths that you can kind of take many of the myths and categorize them under four main domains. One of those is this belief that those with mental health challenges are inherently weak, or that mental health challenges occur due to characterological weakness, and that they have to be taken care of, and others should make their decisions for them. And while we know from research, from clinical practice, from being human, that that's not true. That's not a universal truth. The fear of that plays a really large role in help-seeking behavior for clinicians and for medical providers and doctors and nurses. And I think that's really important for us to notice as a field, to think about how can we change the dialogue around that? How can we really challenge that myth? Because we know the data does not back that up. The other is, and I think this one is one that's somewhat unique to providers, is that our training has taught us that we have to figure out what's happening, to figure out how to solve it. We're problem solvers, we're fixers in a sense. And a lot of times that can be turned internally in thinking that I need to solve this myself. To be a good provider, I must be able to solve my own problem, solve this for myself. But then that also brings up one of the other biggest barriers, which I think is kind of systemically a large challenge, which is across the board, lack of time continually was reported as one of the biggest barriers to seeking help. I think this does get back to that idea of how we approach struggling. Do we reach out for help or seek help or acknowledge we're struggling, or do we put our head down and work harder, work longer, try to make that change ourselves? And so just from a clinical standpoint, I think it's important for all of us to reflect on how we approach struggling, how we approach work-life balance, how we approach time management, and really kind of reflect for each of us, what is it that drives our willingness to seek help or social support, or just even connect with friends and family when we're feeling overwhelmed? And what role does time play in that? And is there a way that we can make additional time for ourselves to have work-life balance? So when we think about all of these different pieces that are somewhat unique to providers, but also are seen in the community as a whole, I think these can be especially challenging because we may know the statistics, but unfortunately emotions don't always follow that same logic. The fear of these outcomes can be incredibly powerful even when we know the statistics around mental health. And so as providers, I think it's important for us to also acknowledge the discrepancy between the two, so we can come up with strategies to help us combat that fear and be able to seek help when it's going to be beneficial and when we need it or when we want it. And so now I'd like to kind of just shift for the last few minutes before we open it up for Q&A, just to talk a little bit about what can we do. Many of you that are on are probably thinking, all right, so the title of this talk was Reducing Stigma. And now you spent the first 10 or 15 minutes just painting a bleak story. Are you sure you know what you're talking about? And why are you the one that's here? I promise there are strategies that we can use. And I plan to talk about them specifically, but I just wanted to make sure to kind of set the stage for all, to be very real with everybody, to acknowledge that stigma exists. And so it is something that we have to actively seek to challenge. And so when we think about how we do that, the literature has shown us three main methods to reducing mental health stigma that are the most effective across the board. The first of which is education, seeking and challenging misinformation, and actually noticing where maybe those overgeneralizations or that, that information isn't quite accurate, and how do we seek good, high quality empirical information about mental health that we can use to motivate ourselves, to challenge internalized self-stigma and challenge stigma more broadly within the medical field itself and the community. The next is contact with others. And while this is an incredibly powerful one, especially kind of more broadly in the community, it's a particularly challenging one for us as providers sometimes. Because within the medical field, we don't, and even in the mental health field, we don't really openly talk about mental health challenges for providers. It's just something that there's almost this unspoken rule, like we're just not going to go there. I do believe that that's been getting better over time, and I'm very happy to see that. But I think that contact with others can be a very powerful way to challenge internalized stigma and not feel so alone if you're struggling with mental health challenges. And to reinforce that you can be a provider and have challenges and be very, very successful. They are not mutually exclusive. And so in line with this, I do encourage people to look for whether it be peer support groups, whether they're focused on mental health or not, just to have a place where you can meet with other providers, share the experience of being a provider and some of the stressors and challenges that go with it. Look to organizations like the National Short Center, who have a lot around helping clinicians and providers kind of bolster resilience and help maintain compassionate care for our clients by also caring for ourselves. They have a number of wonderful opportunities, including a new initiative called Stress First Aid that's been rolled out that's focused on helping to better be aware of stress levels for us as providers as we go through our day-to-day and deal with challenges. And then the other is empowering yourself. We're going to talk a little bit about this one as we move forward as well. There's also been a number of recent studies that have actually looked at many of the techniques that as clinicians we use with our clients who have mental health or are struggling with mental health or anxiety or depression. For example, one of the biggest ones that comes up is a study in the early 90s looked at a 9-session group therapy program focused on ending self-stigma using cognitive behavioral therapy. The goal was to identify, challenge, and reframe internalized stigma beliefs. And they actually found that after 9 sessions, there was a significant increase in acceptance of mental health symptoms and a significant decrease in the intensity of those self-stigmatizing beliefs, which is associated with greater feelings of self-efficacy and self-confidence. I already talked about this a little bit, but provider support groups and organizations, there are a number of them. Many at conferences, we also see a number of them on Facebook, where people are meeting with colleagues, with peers and other professionals who have shared experience to talk about some of these things that they may not feel that they can talk about kind of within their unit or within their practice. Another one I think is really important, and I really benefited a lot from this, was seeking mentorship. And seeking mentorship outside of your immediate reporting structure. If you have a mentor that you feel like you can connect with, that you can confide in, that you can ask for advice, that you can brainstorm some of the challenges of being a provider, that also doesn't necessarily hold that risk of what if my colleagues, what if my boss finds out, what if I accidentally disclose too much. Finding a mentor that can kind of work with you and share experiences and connect you with the resources can be really, really powerful. And then the other is in kind of looking for that empowerment aspect by kind of reading and watching personal stories. There are a number of wonderful, wonderful kind of stories, TED Talks, experiences from providers talking about this process of reaching out for help, what it was like, the challenges that they went through, but also the ultimate benefits and how it helped to be even a more effective provider, realizing that the more they cared for themselves, the better they were able to care for their patients. And so just to kind of wrap up, I'd like to give one kind of concrete example of how we can use these cognitive therapy or CBT techniques to do exactly what they did in the group, where all of us can do these for ourselves. And so this is actually using a kind of challenging self-stigma or a cognitive restructuring framework, where the first goal is really to identify the self-stigmatizing belief when it comes up, to catch them in a sense. So for example, as a provider, I'm not supposed to need help. I already know the skills. I'm supposed to be able to use them. When we look at that belief, it's important to look at, are there maybe some thinking errors or thinking traps? We call them cognitive distortions. These are kind of shortcuts that our brain takes when we're stressed, when we're overwhelmed, when we're anxious, when we're angry, that essentially try to conserve resources, but tend to, in the long run, actually be more detrimental and reinforce the intensity of those beliefs. For example, all or nothing thinking. If I'm a provider, I don't need help. If I need help, I'm not a provider. That all or nothing thinking can be very, very challenging. Catastrophizing or kind of jumping directly to the worst case scenario, the worst case outcome. Overgeneralizing. One that tends to come up a lot is emotional reasoning. Because I feel this way, essentially emotional reasoning is taking those facts as truth. For this example, as a provider, I'm not supposed to need help. We can see elements of that all or nothing thinking, right? I'm either a provider or I need help. The combination can exist. And oversimplifying that because I know the skills, that should be the same thing as being able to use them. But we know clinically, I always talk with my clients and just in general that knowing a skill or knowing what to do is very different than doing it, because that's only half the picture. The other half is practice. And sometimes we need help with that practice. Even Olympic athletes have coaches. As providers, it's okay for us to have coaches as well. From there, oh, sorry, my computer froze. There we go. The next step is to not take that belief as face value. Don't necessarily take it as fact just because you've heard it or it's been presented that way. Look for ways that you can identify what is the objective evidence for and against that thought. Now, when I talk about objective evidence, I think it's really important to notice that objective evidence is what would hold up in court. If I am pulled over for speeding and I go to traffic court and I tell the judge, it really didn't feel like I was speeding. Like I don't feel like I was going 70 in a school zone. I don't think the judge is really going to care what I feel. What they're going to care is what are the facts of the situation. And so it's important when we're looking at those facts to really be objective about, what is occurring. So for example, there aren't any written rules that providers shouldn't need help or that a provider can't reach out for help. Same way I tell my clients that skills are only half the strategy and practice is necessary. The same applies for me as well. Then looking at, are there parts of my belief or evidence that aren't in line with current science around mental health? For example, we talked about the statistics at the beginning that mental health challenges are universal, and being a provider hasn't been shown to be an exclusionary or protective factor. In fact, many of the research suggests the opposite because of the level of stress and the unique challenges that are presented for providers. The other is this thought something you tell yourself out of habit, or is it based on the facts? Is it just something that I've picked up and I just tell myself on a regular basis? Or does it really reflect the facts that I identified above? Are any of the words extreme or exaggerated so they're no longer accurate? So this idea of like, I'm not supposed to need help. That's kind of vague. What does it mean to not just supposed to? That isn't really based on the evidence. And then the other is, are you giving yourself credit for the effort, for the resilience, or discounting important aspects of the situation? For example, discounting what's been happening throughout the last year, throughout this pandemic, where you as providers have not had a break, been continuing to do the hardest work day in and day out. Are you giving yourself credit for the unique challenges that you're facing at that time? And how much time and effort is spent caring for others? And will that allow you to care for yourself? Then the other is looking more behaviorally at what can you do to continue to empower yourself to take those steps? One is the more objective belief. Everyone needs help at times, and getting support can help me continue to support others more effectively. From there, you can start thinking about, what are my action steps? What are the things that I can do to take that step towards seeking help and reducing stigma for myself? Is there something I could learn more about that would help me feel not as alone, or help me feel like I have a plan moving forward? Is there a way that I can really test or challenge this belief? Or are there other kind of helpful or adaptive behaviors that I can focus on to challenge that stigma, to allow myself to have that experience of seeking help, gaining support, or caring for myself? I think the ideas of self-care and prioritizing work-life balance can be really tricky ones, but very, very important ones when you think about long-term resilience. And I will say that when I actually run a group for therapists and trainees who also struggle with OCD and related diagnoses and are learning how to navigate the field with it. And one of the things that always comes up when we have that discussion is this idea behind self-care. And is self-care actually acceptable? We talk about how important it is, and we share how self-care should be part of everything. But sometimes that doesn't necessarily match up with the messages that we are told during training of, you have to do all these things. Don't take time for self-care. Make sure you get everything done. If you have extra time, do some of these other kind of advocacy or other outreach options. And so self-care can kind of get pushed down. I think that's really an important one when it comes to challenging stigma, but also maintaining resilience as a provider. So as a whole, kind of as I close and open up for questions, I really just wanted to say thank you all for joining and for listening. I hope that in some ways that this talk at least will provide a little bit of an overview of some of the ways that stigma may play out and some of the subtle ways that it may actually be impacting each of us without us realizing. And that stigma, just being a provider doesn't mean that you don't experience stigma. Everybody can fall into stigma and self-stigma. That's just part of being human. But we also have strategies that we can use to challenge it. And so with that, I just want to say thank you, and thank you again to Megan and Aaron for inviting me, and I'll open it up for questions and discussion.
Great. So I will remind folks to please direct your attention to the Q&A box at the bottom of your screen. And you can also submit questions in the chat. We do have a couple of questions that come in. I'll start with the second one that came in. You had a slide that mentioned using education resources to challenge mental health stigma. And there's a question of, are there any that you recommend?
I actually think NAMI has done a nice job recently. Like, while they do focus on the community, they've also done a little bit of a focus on providers as well. I think others are, honestly, TED Talks seem to have some of the best ones in terms of educational resources. But the others, I think, that are really good, SAMHSA, the Substance Abuse and Health Administration, they do a yearly annual report on mental health, where a lot of that data came from, where they actually break down, in a lot of detail, like who struggles, how people struggle, and that essentially with the idea that it's okay to struggle. I think those are two very, very good ones. To be completely honest, there is a lack of a resource database for individuals, for providers specifically, that struggle. If others have ones, I would love to hear more, because I think it's something that really needs to be put out there a little bit more. The National Short Center, which all of the MGB hospitals do have a shorts rounds usually that takes place. They actually have put out a number of very wonderful resources for providers specifically for resilience. I think that's a really great place to look as well. The National Center for PTSD is another one that does have a providers section. And more recently, we've seen a couple of the associations like ABCT, the Association for Behavioral and Cognitive Therapies, the International OC Foundation is one of the ones where I run a group for providers. And then Anxiety and Depression Association of America have all put out a number of educational material for providers, or NAMI has great infographics just for level setting in terms of mental health prevalence and what it is, what it means to struggle, what recovery is. So I think those are all good places to start. I wish there was a better repository of one that I knew of, but if someone else has one, I would love to hear it, because I think that's something we really need to get out there.
Great, thank you. And yeah, someone just brought up in the chat too about potentially putting up infographics or posters around medical workplaces. So it sounds like the resources you suggested would be a great place to start for looking into that. Another question came in the chat around the stress around residents spending time in the hospital and being on call. So I'm wondering if you could speak to a little bit about the challenge of the culture of medicine and medical education that tends to be systemically anti-self-care, and any sort of changes you've noticed in this in terms of medical education, resident education over the past several years.
How much time do we have left? That's a big question and an important question. I would say that the research, especially on like medical residents, trainees, has actually increased a lot. It hasn't gained as much visibility, but it is there. I will say, unfortunately, like when I was doing a lit review for this on Google Scholar to get to some of those studies, there were like 3 or 4 on the first page, and then it was 6 or 7 pages deep before you found the rest. However, the research is out there and is starting to increase. I do think that in many ways, as a resident or as an intern or as a trainee, trying to build hopefully a collaborative and supportive relationship with your cohort can be really important. Finding mentors outside of like those that are your supervisors or your on-call attendings or otherwise can be really important, just to talk about these pieces. I think the other is working on how do I have this conversation with the medical school or with the other staff to talk about when these limits are here. And then finding moments for self-care is it's easy to say, hard to do. There has been an increase, I would say, in clinical psychology training programs specifically around the issue of self-care because of the amount of burnout and I think the amount of people who have ended up leaving the field because of it. And so it has been a little bit more of a focus. But anything you can do to collect data, and even like burnout data, can be really powerful for facilitating that discussion and kind of helping to work as a group. Because I think we all know it's there. Just sometimes, a lot of times, we're a little concerned about bringing it up. Also working with your professional organizations, because a lot of times, a lot of these professional organizations actually do have ongoing work to try to essentially reduce that issue specifically. And they may actually have some resources that aren't widely published, but that they can connect you with, or may have things that are kind of in play. Not being an MD, I can't really attest to like the attending process in a hospital. I do know it's discussions that we have in our clinical training programs for psychologists, specifically in inpatient and residential, and it's one that comes up a lot. I think the hardest step is in having that initial conversation.
Great, thank you so much. There's a question that came in about using digital equipment like apps or such to tackle stigma.
Yeah.
And wondering if you knew of any or could speak on that a little bit more.
Great idea. Definitely an area to create. I do believe, if I'm not 100% sure if this is still around, there used to be from CBITS, which is the Center for Behavioral Integrated Technologies, they had a mental health suite of apps. They're from the Northwestern University. And if you just Google CBITS and mental health apps, they'll come up. They're one of the biggest players in that space. One of their apps was actually a Stigma app. It isn't specific to providers, but it was essentially a method of trying to reduce stigma and notice stigmatizing beliefs. So that might be one place to start. There aren't a lot of like very specific apps designed to target stigma itself. In terms of using like a cognitive behavioral approach, there are like the CBT Diary is one app that's really good. There are a number from Veteran Affairs, from SAMHSA, where they've actually rolled out cognitive behavioral strategies on your phone that you can use kind of the same way that the example that I walked through. And those could be a good place to start. And then maybe creating that, because there definitely needs to be more, and there really isn't a lot at the moment.
Great, thank you. Here's a really good question. So, how have you handled moments of self-stigma that come up throughout the workday? What has been important for you in overcoming challenges associated with those moments, specifically that lack of motivation that can accompany self-stigma?
Oh, great question. I feel like all these questions could all be entirely separate topics and talks. I will say, in all honesty, initially, I probably didn't do the best job of it. I did kind of for a while internalize that mentality of just put your head down and work harder and prove it wrong. So in a way, I did take that as the stigma as motivation of like, I have to prove this wrong. I will say at a certain point in my career, I started to realize like I was proving something to myself. Not initially, I was proving something to other people, but then it kept going. And then I'm proving it to myself, but I'm not 100% sure why anymore. I'm just doing it because that's what I've been doing. That wasn't always the best way to do it, to be honest. I think the way that I have tackled it a little bit is actually trying to be a little bit better about reaching out to support and talking with some of my peers and colleagues and developing a network of people that have kind of a shared experience of that, whether they have a mental health diagnosis or not. I think it is a shared experience for providers, especially in like intensive and inpatient settings. That's one way that I've done it, is having that connection with others. The other is being kind of almost reflecting on the reasons why I'm doing what I'm doing, and actually searching for those things that give my day the most meaning. I know personally, I hate paperwork. I think many of us probably do. It's also one of the biggest contributors to burnout, evidently, in some of the new studies coming out. It's administrative work, but we have to do it. And so like when that will come up, sometimes I'll kind of focus more on why the positive aspects of what I'm doing. I'll remind myself of like, clinical cases that went really well, that were really rewarding to work on. In the moment, the other piece is I'll try to use those kind of, acceptance commitment therapy skills in terms of like cognitive fusion, where I try to take a little bit of a distance from my thought, where I might notice that they're there, but try to not necessarily get pulled into the fight with it, and just notice it, and then say, all right, I'll tackle this later. At the end of the day, there are times where I will kind of go and reflect on like what was it that was kind of catching me off guard and pulling me away from the moment and taking my motivation away, and actually go through and restructure it and challenge it. My wife is also a psychologist, so I guess in some ways that's the other way. Is sometimes if I don't catch it, she'll catch it and be like, I'm like, oh yeah, that one. So I think one is just starting to notice it and challenge it, and use the same skills that we use for anxiety and depression because we know that they work. Sometimes we just don't want to do them, and that can be helpful to kind of get into the habit of doing it on the fly.
Great. I'm going to combine a couple questions, like one that came in the Q&A, one that came in the chat. So the first was a concern about, getting tips and resources, or finding a way that people can work on their mental health when they feel like the culture that they're in just dismisses it. And I think tied to that, another question that was targeted on something related is about past or current campaigns that actually target mental health stigma in providers, and like what works and what doesn't.
There haven't been a number of campaigns that target it in providers. There have been some studies that look at some of the stigma reduction protocols. I think the tricky part, and this is actually one that we've been discussing a lot as part of our Schwartz committee here at McLean and our stress first aid rollout that we've been working on, that what we see is, especially if like you tend to work in mental health or behavioral health in some capacity, there is this feeling of like both you talk about it more, but then there's a added pressure that you're supposed to know the skills better. And so when you get presented with some of the basic skills, it can kind of be like, well, I already know this. Why am I sitting here listening to it? Now I don't have less time to work on it. And so I think some of those campaigns can be very helpful because a lot of times those basic skills are empirically proven to help with resilience, especially following, I think the National Center for PTSD does a wonderful job about supporting clinicians and strategies for supporting clinicians who work with trauma, knowing that that tends to increase the risk of both mental health challenges, trauma reactions. And there is actually now in DSM-5 a specifier for if you work with trauma and you're continually hearing people's experience of trauma can cause PTSD as well, PTSD symptoms. And so they actually have some wonderful resources. In terms of overall campaigns, I actually don't know of many. That's one of the areas I've been trying to build out, is finding like resources and putting them all in one place, with kind of talking about what it's like to be a patient practitioner. There hasn't been a ton. McLean hospital has done a number of webinars on it, which I think have been really good. And then I think stress first aid from the National Schwartz Center, probably the two biggest right now. I wish I had a better answer. Those are probably the ones that stand out to me at the moment.
Thank you. There's another question in the Q&A about the relationship between a mental health diagnosis in the provider and patient care, and a fear that acknowledgement and pursuit of treatment could temporarily affect or disrupt patient care, or vice versa. And I would love to hear you talk about that relationship a little bit more.
So I think there's two pieces to this. And one is, when working in a field and having your own challenges, one of the most important things is to really be honest and objective with yourself about when you're struggling, whether or not you do need to take time off or not. Not saying that having a mental health challenge means you have to, because that's not a one-to-one, right? But I think the same way we've all gone through periods when we've been working hard for a long time and we know like we need a vacation because maybe a little more agitated at work, really just not having it in a sense. But I think the same applies for mental health challenges. There may be times where if it's starting to impair your work or get in the way of completing your work or your decision making, because if you can't focus on the day-to-day, maybe even taking a small break just to take a little time to reduce that stress. But the other is that I think in a way that is the fear, is that if I have a mental health challenge, or if I acknowledge that I have it, somehow that is going to open the floodgates to I'm not going to be able to do my job. But in many cases, when in the midst of a challenge, depending on and it varies by what challenge you're facing. I think anxiety, depression being some of the most common ones. In the moment, a lot of times, those can take a side seat when you have like we have a medical emergency or clinical emergency. Our brains are hardwired to kind of hone that focus when necessary. Sometimes it's the other stuff like the notes, the talks, the hours on Zoom that are a little bit harder to engage with effectively. So I would say that in many in most cases, people have continued to be effective in their job as long as they are honest with themselves and take the necessary steps. The biggest problem when it tends to affect patient care is when people start to either delay it or deny it or try not to acknowledge it for fear of what happens if I acknowledge it. Then it tends to spiral out of control and can really be problematic for patient care. I do think EAP, and I know reaching out to EAP is filled with a lot of stigmatizing challenges. The other option is reaching out to, if you're in this area, there are so many different mental and behavioral health organizations and providers. Reach out to one outside of your organization sometimes can be an easier first step to seek help, and then have that discussion with a provider. The other is talking to EAP, because there are protections in place for mental health challenges in medical and mental health fields where you can't be fired for it, when they're ADA protected. Can I say that always doesn't happen? I'm never going to say 100% because unfortunately it does sometimes. But I'd say things have gotten much better in the last 10 years, where people are really much more aware of how it can impact day-to-day and kind of care, but that it doesn't mean that you're going to be a bad provider or clinician just because you have it, or just because you had a history of it. I think the thing to keep in mind from a clinical standpoint as a psychologist, we have strategies that have a ton of empirical basis for all kinds of mental health challenges. And the goal is people go back to their lives, and others don't know because they've learned the skills and the strategies to effectively cope with it should it come up, and they're back to the day-to-day life. That recovery is actually the norm. And I think sometimes we forget that. But when you look at like 80-year longitudinal studies, even of schizophrenia, recovery is more of the norm, especially when people engage in treatment early on and they're back to their lives and others don't know. I think that's also an important element, is to realize that it works. We have mental health challenge strategies and skills that are very, very effective and are highly empirically based.
Thank you. And then thinking about institution-wide change, organizational change. So what can institutions from the top down do to decrease stigma?
I think the biggest thing is just starting the discussion about it, and in some ways finding champions to speak about it. That's one of the reasons that I like giving these talks, and that I try to do some self-disclosure and did the Deconstruction Stigma campaign, was for that reason, because it's one thing to talk about it, but then feel like then once the talk's over, you're no longer allowed to discuss it. But I think holding like either discussion groups, but also increasing awareness of EAP, what they do and how they work. I mean, I'll say even for myself, when I came into a hospital setting, it was unclear how much the rest of the hospital knew if you were to reach out to EAP. And that's one that I've heard a lot from many people. But I think being clear about how EAP works, but also making resources available like Headspace, Calm, CBT Diaries, trying to create some of those opportunities for resources for your staff and making them kind of front and present. I think like the resilient workforce resilience campaigns, Megan, Aaron, that you all are doing, I think those are awesome steps because it shows a dedication to it. And I think that makes it easier to discuss it. So I think those are some of the things to do outside of like kind of full organizational change. Even some of the smaller kind of low-hanging fruit are just making it a little bit more front and center and clarifying what is available and what it means to engage in it, because that can also reduce a lot of the anxiety around taking that next step.
Great. And let's close it off with what's one takeaway you hope folks get out of this talk.
I think the one takeaway that I hope everyone kind of hears is that, one, it's okay to have mental health challenges. That means being human. And that talking about mental health and medical health in a similar way is really important. But also, being a provider doesn't make you immune to self-stigma. And that when you struggle with self-stigma, that it's not a reflection of how you are as a provider either. That those are both parts of being human, and you can, as providers, we are in unique situations with a unique level of stress. And it's okay to reach out for help, because a lot of times that can make us be an even better provider moving forward and happier and more fulfilled in what we do. And so hopefully being able to be aware of when stigma plays a role can make it easier to overcome it and battle it and take those steps for yourself.
Well, great. Thank you so much. I'd really like to thank everyone in the audience for their attendance and great questions. I'm happy that you could all join us for the session live. Extra special thanks to Dr. Van Kirk for sharing his time and expertise. And it's just been really great to hear your story and hear about these amazing resources and, you know, the potential for change in this area. I'd also like to thank the other folks at the center who made the coordination of this session possible. As a reminder, we have recorded this session and we will put it on our website later today or tomorrow so that you can revisit this material. You can share it with your colleagues. We are planning another S.C.O.P.E webinar in the next few months around pediatric mental health. So we'd like to keep the conversation going and extend into the pediatric space. We look forward to announcing that date and those details in the future. And you can find that all on our website at primarycare.hms.harvard.edu. Dr. Van Kirk, thank you again so much. And to everyone in attendance, enjoy the rest of your day.
Thanks so much for having me.
Take care.